All right, good morning, everybody, and welcome to the Psychiatry Department Grand Rounds with ETSU. Thank you for joining us, and please note that there is a link to a handout for Dr. Liu's presentation this morning. It's in the chat feature. As you join, we ask that you remain muted just to reduce any background noise and disruption and out of respect for our speaker. I will hand it over to Dr. Chandrea for the introduction of our speaker today. Thank you very much.
Thanks, David. So it gives me distinct pleasure to introduce Dr. Francis Liu. Let me tell you how I know Dr. Liu. Dr. Liu is very, very well known in so many different areas of psychiatry, from cultural psychiatry to psychotherapy to, for myself as a program director, he belongs to the National Association Program Directors, Academic Psychiatry, and multiple other associations. But he is the person who's been pivotal in getting the diversity inclusion components of what we call the ACGME, the accreditation for residency programs. This is for all residencies, not just psychiatry. So he has made a monumental step in that, which I think is something that we all recognize as very, very important. Now, let me read something more directly related to his accomplishments. Dr. Francis G. Liu is the Luke and Grace Kim Professor in Cultural Psychiatry Emeritus at the University of California, Davis. As a Distinguished Life Fellow of the American Psychiatric Association, Dr. Liu has contributed to the areas of cultural psychiatry, including the interface with religion, spirituality, psychiatric education, diversity inclusion, mental health equity, and psychiatry film. He has presented at every single American Psychiatric Association annual meeting since 1984. That is an incredible accomplishment. He was awarded APA Special Presidential Commendations in both 2002 and 2016 for his contributions to cultural psychiatry. And in 2020, he received the American Psychiatric Association's Distinguished Service Award. In 2008, the American Psychiatric Foundation awarded him an Advancing Minority Mental Health Award, and the Association for Academic Psychiatry awarded him its Lifetime Achievement in Education Award. In 2020, the Society for the Study of Psychiatry and Culture awarded him the Lifetime Achievement Award. In 2021, the American College of Psychiatrists awarded him its Distinguished Service Award. Dr. Liu has mentored so many students, graduate students, residents, medical students over the course of his career. His interests lie everywhere from cultural psychiatry to diversity and equity to psychotherapy, so many different areas, and he belongs to so many associations that his CV literally is a book. So this is a very, very limited sketch of his multiple accomplishments. I'm really thrilled to introduce Dr. Francis G. Liu to talk about the DSM-5's outline for cultural formulation and the cultural formulation interview. Thank you, Dr. Liu, for being here and for presenting to us.
Well, thank you very much for that kind introduction and for your invitation for me to join you today. I want to help you learn more about these two DSM-5 tools that you can immediately employ in your work with patients to optimize your differential diagnosis and your treatment planning. And so a handout of my slides and backup material has been distributed. And there's a second handout of diversity, equity, inclusion, and anti-racism resources as well. I have no disclosures. My email address is listed. If you have any questions after today, please email me. Our learning objectives today will be to focus on our two tools and the supplementary modules of the CFI. This is an outline of my talk. I will start first with what is cultural competence and why is it important, focusing on quality of care issues and training. And then we will look at a roadmap of where cultural issues appears in DSM-5, our two tools, and I'll highlight changes from DSM-4 to DSM-5. This one-sentence definition of cultural competence from the Joint Commission states the ability of healthcare providers and healthcare organizations, individual clinicians, as well as systems of care, to understand and respond effectively. Those are two verbs there. Understanding is one thing, but responding effectively is another. To the cultural and language needs. And language is made very explicit here for obvious reasons, brought by the patient to the healthcare encounter. So this involves every patient every day. And here is my elaboration of this definition. I see cultural competence as an elephant with different parts. So you see 5 parts here. These are all essential. And cultural competence is a journey. Ongoing. It's not a destination that you arrive at exactly, because it involves an ongoing self-assessment of your own cultural identity, values, prejudices, and biases. Then secondly, the attitude of humility about the limits of your assessment and treatment, knowledge and skills. This is essential. This is like the ground that you should stand on to ask, don't assume. Thirdly, the attitude of valuing diversity, to be curious about it, to see how it makes a difference in our assessment and treatment, as opposed to saying, well, I just treat all the patients I see the same. Third, ensuring safety in the clinician-patient power relationship, being attuned to that, and that touches into the cultural elements of the relationship between the clinician and the patient, which I'll be getting into. And lastly, is responsiveness to cultural diversity by adapting our treatment, our assessment and treatment. I'm now going to go over 4 landmark reports that kind of provide the constitutional basis for why we should care about this. This very important landmark report, now 20 years old, said that our healthcare system need to improve in terms of quality, and they listed 6 quality outcomes as goals. First of all, patient-centered care that is respectful of and responsive to, so you can see the 2 verbs again, to individual patient preferences, needs, values, and that's aligned with the concept of culturally and linguistically competent care. And then equitable care, providing care that does not vary in quality because of cultural identity variables. Now, the word quality here is essential to understand. It doesn't say providing care that does not vary because of cultural identity variables. It says quality. So this aligns with the concept of eliminating or reducing disparities. Health equity and eliminating disparities are 2 sides of the same coin. Second report came out a year later from the National Academy of Medicine, which documented for the very first time that racial ethnic minorities received lower quality health care, even for controlling for a number of variables as listed. And we've seen this tragically in this past year with the pandemic. And the reasons for that are, on the one hand, systems-based, systems cultural competence, but also clinical cultural competence factors related to the clinical encounter, suggesting bias and prejudice of clinicians, stereotyping, and clinical uncertainty. Now, stereotyping is a very serious problem when we talk about cultural competence, because sometimes people read a chapter in a book about working with the Chinese and they think they know it all and say, well, I'm just going to apply this to every Chinese patient I see. Now, that may be completely mistaken, because the cultural identity of your patient may go beyond just race, ethnicity. And in fact, if you did that, that would be an example of stereotyping. And when we speak about biases, we need to think, of course, of the intended, conscious, and explicit biases, but also we have unintended, unconscious, and implicit biases. So if you just Google implicit bias Harvard, you'll come to that famous test where you can learn more about this concept. And of course, these biases can cross many different cultural identity variables. And this could be related to our own personal development, our culture as a whole, in terms of the history of slavery and Jim Crow, history of xenophobia against Asian Americans. It can also be related to our profession. So homosexuality was a mental disorder until 1973 in the DSM. And the bias against religion and spirituality in psychiatry and psychology pervaded much of the last century. Now, the third report was from the Surgeon General, David Satcher, on culture, race, and ethnicity, which documented again for the very first time that racial ethnic minorities received poor quality mental health care. And this is the last report, a follow-up report edited by Pedro Ruiz, a past president of APA, and Anel Prim, deputy medical director of APA at that time, that again showed that disparities existed not only for racial ethnic minorities, but also related to other cultural identity variables, populations, diagnoses, and places of care. In terms of training, I wanted to point out quickly 4 accreditation standard competencies that we expect residents to learn and demonstrate in their training. So this obvious one here about competence in evaluating treatment of patients from different cultural identity groups. Now, if you dig just a little deeper, or what underlies this process of evaluation and treatment is the competence in forging a therapeutic alliance. Again, this is bread and butter. We know this all wrong. Now, underneath that, one element of the therapeutic alliance is the cultural elements of the relationship between the resident and the patient, including dynamics of difference in identity, values, preferences, and power. And this aligns very much with the 4th part of the outline for cultural formulation that I'll be discussing in just a moment. The last one is professionalism, that residents are expected to demonstrate sensitivity and responsiveness, again, the 2 aspects, to a diverse patient population broadly defined. Now, turning to our roadmap, in the introduction to DSM-5, we do have a few pages that discuss cultural issues and gender differences. Then the bulk of DSM-5, the section 2, for some of the diagnoses, there are culture-related diagnostic issues sections and gender-related diagnostic issues sections. The page numbers here refer to DSM-5. Some diagnostic criteria changed. I'll show you an example of that. And then there are the other conditions that may be a focus of clinical attention, the V codes in the back of DSM-5. Then in section 3, there is a section entitled Cultural Formulation, where our two tools are described. And that's in your handout material. I have copied all of that for you. And then in the appendix, there is a glossary of cultural concepts of distress, which replaces the glossary of culture-bound syndromes, which appeared in Appendix I of DSM-4. That term, culture-bound syndromes, no longer exists in DSM-5. And that's also, this glossary is also in your backup material. So in the introduction, there is a description of culture. What do we mean by culture and how does that affect the person? And if you just look at what's in blue, you can see that culture is related to much more than race and ethnicity, to involve a whole range of other cultural identity variables. So it's not just one, but many. And cultural identity is dynamic, not static, meaning that one's cultural identity can change over time and over place. Someone from Vietnam coming to the United States, well, their cultural identity may evolve over time. So that we really do need to understand that we're talking about person-centered care by taking into account the intersectional, ever-changing, highly individualized cultural identity of each person receiving services, as opposed to stereotyping. And I'll come back to this when I cover this part of the outline. Now, here's an example of culture-related diagnostic issues section for schizophrenia. This existed in the DSM-4, acknowledging that when we do have cultural identity differences, we do need to take these cultural factors into consideration. And they give then two examples. Ideas that may appear delusional in one culture may be commonly held in another. And that in some cultures, visual or auditory hallucinations with a religious content, such as hearing God's voice, are a normal part of religious experience. And then this sentence was added in DSM-5 to explain that a little bit more. So let me just illustrate this. You ask a patient, well, do you hear voices? And the patient says, well, I hear God's voice. So this section is meant to say, stop, they're like stop signs, ask, don't assume. So instead of just saying God's voice, well, that's an auditory hallucination, that's a psychotic symptom, that means the person has a psychotic disorder or a mood disorder with psychotic features as a possible diagnosis on the differential. So before you go down that track of psychopathology, which we're all trained to do, ask, don't assume. Well, where do you hear God's voice? In church. And how often? Well, every Sunday. And how long has this been going on for? Well, 20 years. And my family goes to church and we hear God's voice all the time there. So you might say to yourself, well, that sounds like it's part of the person's culture. But you need to ask more. You need to say, well, has anything changed recently? Oh, yes, I'm hearing God's voice outside of church. And how long? Well, the last couple of weeks, and it's getting louder, and the voice is telling me to jump off the bridge. Well, then that does sound more psychopathological. And sometimes it's a combination of both. So that's our job as a psychiatrist, to do this differential. And the question here is, what's cultural, what's psychopathology, and the possibility that it could be both. Here's an example of a change in the diagnostic criteria for panic disorder. This was added based on research in cultural psychiatry, that some people have these kinds of distressing experiences which should not be counted as part of the 4 required symptoms. Now, turning to the V codes, This is the introduction to that section. As you can see, these are other conditions or problems that may be a focus of clinical attention and may affect the diagnosis, course, prognosis, or treatment of a patient's mental disorder, and that these can be coded as part of the diagnosis. But important to remember, these are not mental disorders. They're not mental disorders. So consequently, I think because they're not mental disorders and our job is to diagnose and treat mental disorders, we tend to just forget about this section, especially because these V codes are not billable, they're not reimbursable. So who cares about them? Okay, that's certainly very understandable, but I would like to bring to your attention another look at it. And that is, these are the categories of those of these distressing experiences. And for each of these categories, there are specific codes for more specific things. Now, the next couple of slides are from Michael Compton and Ruth Shim, who co-edited a book in 2015 called The Social Determinants of Mental Health. And here you see 16 social determinants of mental health. The yellow ones are the ones they wrote about in their book, the 10, and then the 6 white ones are the new ones that they've written about. So in the lower left corner, there is adverse early life experiences, which has been understood since the 2000s. And right next to it is discrimination and social exclusion, social isolation, very pertinent to what's happening in the country. And then in the upper right is climate change, which is a new one. And for each of these social determinants of mental health, there is a V code that maps onto it. In other words, visually speaking, the V codes I see are like the tips of the iceberg that you can see that the patients complain about. But underneath what their complaints are these icebergs of these social determinants of mental health. And this is their latest rendition of this, where they've grouped the 16 into 4 little blocks. And also to point out that underlying these social determinants of mental health are the social drivers or the structures involving public policies, social norms, and this concept of justice. So there's a book that just came out, edited by Ruth Shim and Sarah Vincent, called Social Injustice and Mental Health. So let me give you 3 quick examples. One is acculturation difficulty, again, and these can be coded in addition to any mental disorders that you diagnose. A recent immigrant may be having this kind of problem, and this optimally should be part of the diagnosis if it's relevant, and then the treatment plan should address this in some way. And then there's this one, which I think is, again, very pertinent to what's happening in the country, is that a patient may be complaining about this or may be distressed about this. What do you do with that? Do you simply say, say to yourself, well, that's not part of a mental disorder, so I'm just not going to care about it? No. I would say that in order to be respectful of the patient, one needs to be empathic and hear about it, but not simply stop here either. See, if you just stop here and say, oh, all your problems are discrimination, that's not quite right either. So again, we need to hold both at the same time. And this is the last example. This is one that I helped to get into the DSM-5. These are distressing experiences involving a loss or questioning of faith, or someone having a mystical experience or a near-death experience and feeling very distressed about it. Am I going crazy or not? Again, these should not be seen as symptoms of a mental disorder, but a religious or spiritual problem. Now, turning to our two tools, the DSM-5 outline for cultural formulation, and you have all of this in your backup material, first appeared in the Appendix I, the 9th appendix of the DSM-4, and that's why a few people even knew about it. And it was revised for DSM-5. So what's in yellow is DSM-5, what's in white is DSM-4. And there are 5 parts. The first 4 parts are fields of interrelated information that we're asking the clinician to gather. And then the 5th part is the call to action. So these are the cultural identity of the individual, the cultural concepts of distress, the cultural stressors and supports, the cultural features of the relationship between the individual and the clinician. You see how that ties into the accreditation standard. And then the overall cultural assessment, meaning how does this affect your differential diagnosis and your treatment plan? That's the responsiveness part. What are you going to do differently? How does this information help to inform your differential diagnosis and your treatment plan? Now, the Cultural Issues Work Group for DSM-5, headed by Roberto Luis Fernandez, and I was part of that 30-person work group, felt that it would be important for clinicians to have some questions to ask the patients to gather the information for the outline for cultural formulation. So we have, these are the 4 clusters of the questions that I'll be discussing now. There's a patient version, and you have all of this in your handout packet, and an informant version. And then we have 12 supplementary modules, which you access online by Googling supplementary modules DSM-5. Now, these are lists of additional questions for deeper dives. So in the core CFI, there are 3 questions related to cultural identity. But if you wanted to explore that more with the patient, here is a list of additional questions to ask. So these are like deeper dives into the different aspects of the outline for cultural formulation. But the last 4 are concerning specific patient groups. As you can see, children and adolescents, older adults, religion, spirituality, and immigrants and refugees. So if you have patients that fit into these categories, you might consider looking through these questions as well. So this is what it looks like at the beginning of the CFI in the DSM-5. Now you can see it's not just a list of 16 questions, but you have a guide to the interviewer in the left-hand column and instructions and actual words that you might use to help you do this. And so you can see number 1 is what brings you here today. So hopefully you're doing that already. You're already doing 1 of 16 questions. So now I'm going to go through the 16 questions in the order they appear in the CFI and relate the 16 questions back to the outline for cultural formulation because they're not in the same order. And the reason for that is that we thought that what brings you here today would be the natural place to start, as opposed to saying, well, what's most important about your background or cultural identity? So, so what brings you here today? The patient might say wind illness. And then you would say, well, sometimes people have different ways of describing their problem to their social network. How would you describe your wind illness to them? So in my presentation here, whenever you see the brackets and problem, we'd like you to use the patient's own words. So what troubles you most about your wind illness? Then the next two questions relate to cause, explanatory model. Why do you think this is happening to you? And what do you think are the causes of your wind illness? And what do others in your social network say are the causes of your wind illness? So this relates to part B of the outline. And again, this is all in your handout packet. The cultural concepts of distress are ways that individuals experience, understand, and communicate symptoms. And there are three subtypes or three entities. There could be cultural syndromes, idioms of distress, or explanatory models. Now, these three terms are actually defined on page 14 in the introduction. And so the idioms of distress are like the chief complaint, the words that the patients may use. Cultural syndromes are a clustering of these, and the explanatory models relate to the issue of cause, what's causing it. And then it says you need to assess the severity and meaning in relation to the norms of the individual cultural reference groups. So that's why, as you can see, 2 of the 5 questions had that social network piece to it. And you need to understand what is the cultural reference group of the patient. That's what's the cultural identity of the patient. And then the last sentence here is the assessment of coping and help-seeking patterns, including professional, traditional, alternative, or complementary sources of care. Now, this part we will get to when we get to questions 11 to 15. And notice that we are going beyond professional care to include the traditional, alternative, or complementary sources of care. So that means like the acupuncture, the herbal medicine, the Tai Chi that the patient might be doing should also be part of the inquiry here. Now, the glossary of cultural concepts of distress appears in the appendix, and we have here 9 examples of well-studied cultural concepts of distress. Now, there are more than 9, but we just have 9 in the book. And here's a table where that kind of describes this a little bit. On the far left are the actual names of the concepts. So when you ask the patient, well, what brings you here today? They might say nervios. And then in the middle column, it's which of the 3 subtypes that we have here. And some of these are related. So like nervios, as you can see, is an idiom of distress. And at the top is ataque de nervios, which is a cultural syndrome in which nervios is a part of. And in the far right column are regions in the world where we see this. And of course, we're interested in this because patients come from all over the world to the US. So this book is a cautionary tale. This is based on a true life story of a Hmong infant who had a grand mal seizure treated by a neurologist and a pediatrician in the Central Valley of California. And they had a purely biomedical explanatory model. And of course, medications as the biomedical treatment. Problem was the family had a supernatural cause to what was happening. And they called it, in fact, the spirit catches you and you fall down. And so they didn't understand what medications had to do with it. And it led eventually to non-compliance with the medication, and the child had a prolonged grand mal seizure and lapsed into a vegetative state in the 90s and died about 2012. It was in the New York Times. Next two questions of the CFI. Are there any kinds of support that make your wind illness better? And are there any kinds of stresses that make your wind illness worse? So these two questions relate to part C, as you can see here. And what's in yellow are like the key terms to remember, if you can. Identify the key stressors and supports in the individual social environment, which may include both local and distant events. And there are three domains: religion, family, and other social networks. Now, religion and family was in the DSM-4. Added for DSM-5 was other social networks. And then there's a further description about this, about how this is related to culture and how we need to think about resilience, which is added to DSM-5 for the first time. Now, let me expand on this a little bit. When we speak about the local and distant events, stressors, one way of thinking about it, local meaning geography, local meaning the interpersonal relationships across those three domains, religion, family, and social network. But another way of thinking about this are the social determinants of mental health. And that could be local by geography or time, something that's happening, now, or, like a hurricane is hitting us right now. That's, it's here and now, a hurricane, okay? But also it can be distant by geography or time, meaning climate change, affects the whole world. This is distant as well. And distant in time in the sense of slavery or Jim Crow or xenophobia or the Holocaust, and causing intergenerational trauma. So that's distant in time. So that's back to what I mentioned before earlier. Now, when we talk about supports, again, the idea is we're always interested in supporting our patients, finding out, the protective factors or the resilience factors, and how do we optimize them in our treatment planning. And so if you put on the cultural lens, if you ask this question from a cultural perspective, you might see more. That's the point. So Pamela Hayes, in her book that I'll reference in a moment, talks about a whole range of possibilities here. And so here we see extended families may be very important, and religious communities. And then towards the bottom there, involvement in political or social action groups may be very important to some of our patients. And here we have things like caring for animals, which we know are very important to some patients. And then in terms of religion, spirituality, so forth, I would recommend looking at that supplementary module, which gives you additional questions to ask about. We're here specifically focusing on the practices, rituals, and ceremonies, either individual or faith communities, so prayer and so forth. How does the patient practice, and how does this affect their problem? In terms of family, again, a genogram is helpful, not only the nuclear family, but the extended family. And how is family related to ethnicity and acculturation? And I really recommend this book, Ethnicity and Family Therapy, which has 52 chapters, not only on Japanese families and Vietnamese families, but also Irish families and Italian families and Russian families. So here you have these references for your further review. And then the next three questions relate to cultural identity. For you, what are the most important aspects of your background or identity? And are there any aspects of your background or identity that makes a difference to your wind illness? And are there any aspects of your background identity that are causing other concerns or difficulties for you? So that's kind of a second pass question to ask about other things. And so let me expand on what this means. Again, this relates to the first part of the outline for cultural formulation. This is what we saw in DSM-4. As you can see, there's a mention of race and ethnicity and the concept of biculturality. To what extent are you involved or aligned with the traditional culture or culture of origin versus the American culture, the host culture, and then language. Added in DSM-5, very important, is this sentence, which explicitly expands the number of cultural identity variables for you to think about and to consider. But even these list is not final. For example, it's missing age, it's missing gender. So let me give you two two pictures to put so you can understand this. One is the word addressing, which is an acronym that Pamela Hayes uses in her book, Addressing Cultural Complexities in Practice. And as you can see, for each letter there, it references a particular cultural identity variable for us to think about. However, this is not a complete list because, as you can see, language is over to the right in brackets because there's no L in addressing, and language is a very important one. Here is a diagram from thinkculturalhealth.hhs.gov, where there's an e-learning program on cultural competence that I do recommend, and that's listed at the end of my slides here. The cultural identity variables go from 8 o'clock to 12 o'clock to 4 o'clock. And as you can see, there are a number of them. And what we're interested in is that quality of intersectionality, a very important concept. And in this diagram, how that then intersects with the health beliefs and practices, that's part B, and the environment, that's part C. So again, ask, don't assume. Asian, there are many subgroups of Asian. National origin doesn't define a homogeneous ethnic group. You do need to ask. You can't determine someone's cultural identity just by looking at them. And cultural identity is critical. It affects all the other aspects of the outline for cultural formulation. And when that question about are there other concerns about your cultural identity? Well, here are some of the illustrations of that. There could be intrapsychic stress related to cultural identity conflict. So a Vietnamese adolescent who was born in the United States versus their Vietnamese parents that were born in Vietnam, are traditionally acculturated. That person might ask themselves, how much am I Vietnamese? How much am I an American? Sexual orientation conflict. Am I gay? Am I straight? Religious identity. Someone brought up a very strict Catholic may be questioning, to what extent am I aligned with that strict Catholicism now? Then there could be interpersonal conflict. So that example I gave earlier of the Vietnamese adolescent who may be more English speaking and American value oriented may have conflicts with the traditionally acculturated parents. And then at the social level. Now moving to questions 11 to 15, we come back to that self-coping and help-seeking pattern by asking about self-coping and past help-seeking. And then the barriers to care. And these are all very important because the barriers that the patient may have had in the past may be barriers they'll have in the future. And that's directly relevant to your ability to care for the patient. And the past help seeking, may give you a clue as to what they're expecting of treatment now. Now, these next two questions are kind of take-home questions what kinds of help do you think would be most useful at this time for your wind illness? And are there any other kinds of help that your social network would suggest? So this relates back to that section B that I mentioned. And of course, just to illustrate this, the patients may have had no care prior to mental health, or maybe they've gone to primary care, with their somatic complaints and negative medical workups, and then they're referred to us. Or maybe they go to complementary medicine or religious healer. So we need to just understand that this is par for the course, and we just need to appreciate this, as opposed to calling the patient treatment resistant. So that's just some pictures of other treatments and listing of other treatments and methods that people might be using. So the last question of the CFI just touches on the clinician-patient relationship. Sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this? And is there anything that we can do to provide you with the care that you need? Now, this is really a very important question. I know it's at the end of the CFI. You may feel you just can't get to it, but this is really critical because this touches in to part D, this cultural features of the relationship between the individual and clinician. Again, what's in yellow was added in DSM-5. So identify the cultural identity differences between the individual and the clinician. And language and communication was added here for obvious reasons. Now, very important is this sentence. Experiences of racism and discrimination in the larger society may impede establishing trust. So again, things that have been happening, in the US recently, George Floyd or the shootings in Atlanta, may be, for a particular patient, may be quite of concern, and that may be brought into the doctor-patient relationship. And the effects here might be misunderstanding what's cultural and what's psychopathological, and eventually impacting on the therapeutic relationship, Now, how do you operationalize this? So let me give you 4 steps, and then let me give you 4 quick examples. The first step is for the clinician to understand their own cultural identity. The second is to compare the cultural identity of the patient to that of the clinician. So you can draw a little table. On the far left are the cultural identity variables like age, race, ethnicity, gender, religion, and so on. In the middle, you put the patient's cultural identity variables. And in the far right column, you put your cultural identity variables, and you look at the similarities and differences and what might happen with those similarities or differences. Now, one thing we need to keep in mind here, of course, is this idea of bias, is that because of differences, the clinician may have a certain bias against the patient, or the patient may have a certain bias against the clinician. And then more broadly speaking, the third step here is we need to look at how these similarities and differences affect different aspects of the relationship. And these are listed here. And again, we're concerned about this day in and day out. And the idea is put on the cultural lens and see what more you can find. And the last step then is how do you, what can the clinician do to provide optimal care? Sometimes cultural identity matches are important. Other times, it's a matter of getting a cultural consultation or a consultation from a faith healer or cultural broker or a clinician from the department who may know more about that particular culture, or PubMed search or reading books. So now let me give you 4 quick examples, and I know I have about 10 minutes left here. I'm Chinese, I only speak English, and my Chinese patient comes up to me and starts speaking Cantonese, assuming I speak Cantonese. Well, here we have a language difference as causing problems in communication. So I need to respond, I need to adapt by getting a trained interpreter or working through a Cantonese speaking clinician or referring the person to a Cantonese speaking psychiatrist. That's an example of where a cultural identity match may be quite important. Second example, I'm a man and the patient's a woman. First interview. Patient's reluctant to give me any information. At the end says, well, you know, doctor, I'd really rather have a woman psychiatrist. So what do I do with that? Do I take offense? Do I say, well, patient's treatment resistant, passive aggressive, and, you know, go down the psychopathology track? Or do I ask, don't assume, tell me more? Patient at the end says, well, I'm really reluctant to get into it. I had a difficult time with my husband. And okay, so the story comes out, you know, sexual abuse, doesn't trust men, would rather have a woman psychiatrist. That's an example where cultural identity match may be very important. Third example, I'm a Biden Democrat. Patient comes in as a middle-aged man with a red cap that says, "Make America Great Again." And he looks at me and says, well, what country are you from? Well, here we have a difference in political orientation, and patient's bias, if you will, is coming up immediately, and it's affecting our relationship. And I may have a lot of countertransference feelings about this. And how am I going to deal with this? Fourth example, I'm an atheist, and I ask the patient, well, what brings you here today? And the patient says, well, I've lost my faith in God, and God is punishing me for my sins. So here we have a difference in religious commitment. And what do I do with that? Do I say, well, you know, I don't believe in God. Why is God important to you? And so I'll just ignore discussing this, or worse yet, I'll psychopathologize this. And the patient feels disrespected, not responded to, drops out of treatment. So we have to watch about our own countertransference to these sorts of issues. And what I've talked about is focusing on the relationship between the patient and the clinician, but these cultural differences also exist between trainees and supervisors and the supervisors of the patients. So we need to be aware of this and how it affects our work. So this is the last part of the outline, and there are no CFI questions for this. This is for us to jump off into, if you will, and that is take all of this information. How does it affect your diagnosis and the other clinically relevant issues or problems? I think that's the V codes. And how does this affect your treatment? So we want to, of course, have an accurate diagnosis as much as possible, and that starts with a complete differential diagnosis, because misdiagnosis can lead to mistreatment. And we've given some examples of that here today. So what do? Well, one is go to those stop signs, go to those culture-related and gender-related diagnostic issues sections, where you'll find discussion about differential diagnosis at the phenomenon and disorder level, as we saw for schizophrenia at the phenomenon level. But there's additional language concerning like the overdiagnosis of schizophrenia in African Americans. Prevalence will vary, and also course and outcome. I should say here that DSM-5 text revision is coming out later this year, in which all of these narrative sections are going to be updated, and including these culture-related and gender-related diagnostic issue sections. And then secondly is to review and add those V codes so you can map on the social determinants of mental health and address them in the treatment plan. So looking at treatment planning, there is the process of negotiating and managing a treatment plan to maximize adherence and compliance. This is something we're interested in every day with every patient. Are the patients taking their meds and so on? So put on the cultural lens, use these tools, see what more you can see. Are there cultural issues that can make things better here? And then from the content point of view, medication kinetics and dynamics can vary related to race, ethnicity, gender, age, as well as environment, interaction with herbal meds. So we need to be aware of this. In terms of psychotherapy, to first of all respect patient and family expectations. So my deceased colleague in Asian mental health, Evelyn Lee, used to say, be the tiger balm oil at the first interview when assessing traditionally acculturated Chinese patients, because they expect some kind of immediate relief of some small kind. And if you don't provide that, the patient may feel like they're not getting help and they're not going to come back. Some patients need family assessment because they're more family oriented. And then even our usual forms of treatment and psychotherapy can have cultural modifications. There are books now on culturally responsive CBT, and also for our other forms of therapy. And ultimately, what are the therapist's characteristics that would facilitate or hinder treatment, as we've discussed? And turning lastly to social-cultural issues, again, think family, religion, spirituality, and social networks. And then finally, addressing the social determinants of mental health through structural competency. So this is the best book on the outline for cultural formulation, the best book on the CFI. This is an online training that I highly recommend from Columbia. This is a training also on cultural competence. And then we have our Society for the Study of Psychiatry and Culture. There's the website where you can learn more about it. We have our annual meeting coming up. So I'm going to stop sharing and see if you have any questions. You can type in your questions in the chat and I can respond, or you could just unmute and speak.
I'm going to jump ahead and ask you a question because I have been dying to ask you this. So one of the things I struggle with is when I am trying to discuss, I actually did a grand rounds on nothing as wonderful as yours, related to cultural psychiatry, trying to teach about the different cultures, some of the core differences, behaviors that may impact how we interact with them. So if you don't know that, in certain cultures, for example, Middle Eastern cultures, the man has to be present. Often they won't allow you to talk directly to the woman. So one of the things I struggled with, particularly with the political sensitization in this area, is how do you talk about what may appear then very stereotypical from that culture, with that, and sounding as if that somehow limits it in terms of how you perceive the person, and also being aware that when they come to another country, the acculturation process is varied, and they are actually, as individuals, different from others from the same culture. How does one teach those, core, perhaps to some degree, aspects without sounding as if you are in some way being racist about that?
Yes, well, my immediate answer is to emphasize intersectionality, and also that concept that someone's cultural identity can change over time. But it also but there is the possibility that if they're traditionally acculturated, they may just hang on to that. So the point being that this is the ask, don't assume. This is that ground of cultural humility is so important, as opposed to making assumptions that's the slippery path of making assumptions. That will lead to trouble. So in other words, yes, you do. There is a certain amount of knowledge here. One does need to read about these things to have the background, the background information. But in terms of the application to a particular patient, you need to be skillful in understanding the complexity of cultural identity, as I've described here today.
Dr. Liu.
Yes.
I have a question about the V code target of discrimination.
Yes.
Was there any controversy about including that phenomenon as a V code as opposed to as a mental disorder or as a condition for further study? My question arises from the context of my own practice, which focuses on forensics. I have worked in cases where people have alleged psychological injury as the result of discrimination. And under the current system, you have to shoehorn that injury into some other classification in order for it to be recognized, as if discrimination itself cannot be an injury. And paradoxically, I have wondered whether, in an effort to avoid stigmatization or some other reason, relegating this to a V code is actually self-defeating in terms of the overall goals.
Right. Thank you very much for that very nuanced question. I do not know the history of this V code. I should, but I don't, in terms of how, I don't know, for example, if it was in DSM-4 and how it was maybe revised for DSM-5. And I don't know the discussion about, should it, be part of a mental disorder somewhere, as you've described. So I unfortunately don't have that information to give you. Carl Bell, many years ago, did raise the possibility of racism, racist patients as perhaps having a mental disorder of some kind. And I can't immediately think of a book to help sort this particular issue out. But if you will email me, I'll do some research and get back to you. Francis Liu, MD at Gmail.
Thank you for that. I will.
Yes. Any other questions?
I had a quick question, Dr. Liu.
Yes.
Thank you for the presentation. I wanted to ask, kind of with your experience, what do you think our responsibility is being in this space to encourage primary interventions in mental health, given like all those social determinants of health and like the foundation being these public policies and these kind of like societal norms?
Yes, that's a very good question. And I would like to say here that Vivian Pender, our incoming president of the APA, has made this topic of social determinants and mental health her presidential theme. And she is appointing a task force on social determinants and mental health to see how APA can look into this. And I do think that one needs to approach these social determinants and mental health, first of all, at the individual patient family level in terms of how they're impacting right now on the people that you're seeing and to try to address them in that way. But yes, ultimately, or not so ultimately, I mean, the underneath the waterline, yeah, like the Titanic, okay, underneath the waterline are these icebergs that that involve social policy and public policy, social norms that are the drivers, and therefore the APA certainly and interested individual psychiatrists, as their time and interest permit, should focus on these more broader social structures and drivers of social determinants of mental health.
Thank you.
If no one else has another question, I have one last question for you, Dr. Liu.
Yes, one last question, yes.
So what I wanted to ask you is, one of the things I think from a clinician standpoint that one perhaps struggles with is, as you mentioned in the examples, differences in one's religious beliefs, the differences in one's political beliefs, etc. When a patient comes in and asks you, are you this or are you that? I would think that as clinicians, we should be trained to be able to deftly look at perhaps moving it from that, because that's often not the core issue for them. It may be how they are starting it out, but they're able to really, most clinicians can work with most patients, is my thinking, as long as you've got somebody who's sensitive, empathic, and ultimately the bottom line is you care about the patient and their welfare and helping them the best. Because I know we'll often get people that will say, I want to only see a female, psychiatrist, resident or whatever. And what I've found is, if I've suggested that, the patient work with that resident for a couple of sessions, at least as a trial, that usually they get beyond that initial. And that's an enriching experience for the patient in terms of understanding what they perceive as cultural differences, but also for the resident in learning the nuanced ability to work with patients. And I think that's ultimately where we would want to go, rather than perhaps responding right away, unless it's absolutely someone that, as you say, has been so significantly abused that there's no possibility and you would risk losing the patient, to continuity of care. Your thoughts on that?
Yes, I think that sounds about right. I don't think that we, again, it's a judgment call, and my examples were, were very simple examples. And I think what you've brought up here is the importance of always making an assessment. Again, we can't, just because the patient says, well, I need a I need a this or I need a that, we just don't, hop right to it. We need to go through an assessment process. We need to explain, and we need to understand. We need to ask, don't assume. You say, could you tell me more about what you're concerned about, and and so on and so forth. And we see to what extent things can work out. And yes, so I do think that what you've said is correct. Yeah. Okay, well, thank you very much again, and feel free to email me any follow-up questions. And I really appreciate this opportunity to share this work with you.
Yeah, we appreciate your ability and willingness to give us this lecture. It was very, very informative and much appreciated. Thank you.
Thank you very much. In Appalachia, you have your own culture there. There are books on Appalachia. Yeah, look, on the DEIA resource list, there's an Amazon list at the end. And if you go to list number 2, at the end of that list, there's a whole bunch there are a few books on Appalachian culture. Take a look. Okay, take care.
Thank you so much.
Thank you.